I'm Dr. David Song, the Regional Chief for MedStar Health Plastic Surgery and the Chairman of Plastic Surgery here at MedStar Georgetown University Hospital. I'll also be operating at MedStar Washington Hospital Center. Most of my patients come to see me for breast cancer and breast reconstruction. They also come to see me because they have lymphedema, which is a swelling of the arm that some patients get after a mastectomy and after removal of lymph nodes for treatment of breast cancer. As a reconstructive plastic surgeon who deals primarily in breast cancer surgery, we are that integral portion of that plan from the get-go. And so it's important for patients to understand that the options that are afforded to them start from really the beginning, from step one. And even patients that have had breast cancer and treated elsewhere, we're able to offer a whole host of options for them as well. But really, we're an integral part of the team when we treat a patient with breast cancer. Patients with breast cancer and the need for breast cancer reconstruction should come here because we are really the epicenter of treatment for breast cancer, for reconstruction, and for the surgical treatment of lymphedema, really in the Mid-Atlantic region. Many of my patients come to see me having seen other plastic surgeons and having been told they are not the right candidate for this treatment or that treatment, when in fact they really are, and they have a lot of abilities, and we have a lot of abilities to offer the whole spectrum of reconstructive care for patients that have been told that those options are closed to them. The real exciting thing in breast reconstruction now is the ability to connect nerves, and in some patients to restore sensation after mastectomy and reconnecting the nerves to give that sense of feeling and wholeness to the reconstructed breast. When they come to see us as restorative breast surgeons, it adds a balance to their diagnosis. So they're hit with a ton of bricks when they're diagnosed with breast cancer. And for them to see us, we give them hope. We give them a light at the end of the tunnel and the ability to really restore what cancer has taken away. Part of my job that I love the most is really seeing a patient from the throes of a diagnosis of breast cancer and on the other end, seeing them not only survive but really thrive after cancer treatment and a restoration of their femininity and a restoration of their wholeness in the sense of self. So after a mastectomy, regardless of whether a patient has reconstruction or not, patients will lose feeling. Now there are certain things that we're working on now to restore sensation, but by and large, if a patient is not getting autologous reconstruction, meaning reconstruction with their own body parts, the ability to restore sensation is highly limited. But there is hope. The hope is when we reconstruct a breast with one's own tummy tissue, abdominal tissue, there are nerves that we can connect to help to restore sensation, and that's something that's really exciting in our field today. So when we reconnect the nerves, we see many patients having protective sensation, so cold, hot, pain, itching. It's the rare patient that we can't actually see a full restoration of sensation, and most patients are somewhere in between. When a breast is reconstructed with a patient's own abdominal tissue or buttock tissue or thigh tissue, for one breast it can take about 4 to 5 hours. For two breasts it can take anywhere between 6 to 7 hours. When patients are reconstructed with implants, that takes anywhere between 45 minutes to an hour and a half. I hear this a lot, and that is not necessarily true because many patients that come to me are those that have been told they don't have enough fat in their abdomen. But we can take it from the medial thighs, we can take it from the buttock, and even from the back. So there's a whole host of options to use one's own excessive fat in other areas of their body to reconstruct a nice, soft, supple, and natural appearing and feeling breast. When we use one's own body parts that are excess fat in the tummy, thigh, buttock, and back, these reconstructions last for the lifetime of a patient. When we use implants to reconstruct a breast, there is a shelf life, so about approximately 10 to 15 years before implants need to be replaced. It's a patient's choice. So patients oftentimes choose an implant because they want more of an enhancement, or because they're really thin, or because they feel like that's an easier recovery. Operating on the abdomen and the breast, it does lengthen the recovery, but over the course of one's lifetime, once you're done and healed with an abdominal-based reconstruction, or a buttock-based reconstruction, or a thigh-based reconstruction, you're done for the rest of your life. So most patients that have what we call the DIEP flap, which is the deep inferior epigastric perforator flap, taking it from the abdominal region, will have a 6-hour surgery for both sides, 4 to 6 hours for one side, 6 to 8 hours for both sides. Will stay in the hospital on average 3 days and go home. We have an entire team dedicated to pain busting. That starts even before surgery even starts, with an entire regimen of non-opioid based therapies, including medications, injections to numb up the nerves, all with the goal of restoring a patient back to the activities of daily living as soon as possible and keep them comfortable. The potential complications and side effects of implant-based breast reconstruction are really primarily related to the implant. Implants don't last forever, so every 10 to 15 years they have to be replaced. Implants can get infected, rarely. Implants can move and shift, and implants can get hard, and we call that capsular contracture. The potential side effects of using your own body tissues is adverse scarring in the areas that we've taken the excess tissue, incisions that don't heal properly, and then rarely the flap can actually fail, but that's less than 1% of the time. So lymphedema is a consequence of having lymph nodes removed after breast cancer, where the arm actually swells up and the body cannot control the extra fluid because it's blocked. And so that can lead to chronic infection, discomfort, inability to wear one's wedding ring, inability to wear bracelets and watches occasionally. And so what we can do as surgeons is bypass and reroute those lymphatic channels using microsurgical technique, tiny, tiny needles and suture under a microscope to reroute those blood vessels. Also to restore and transplant new lymph nodes taken from other parts of the body that's not necessarily needed and placing them back into the axilla. And combined with therapy and manual lymphatic drainage, we can really improve a patient's quality of life with someone that has lymphedema. Lymph node transplants from other parts of the body can be very successful. In my experience, most patients receive at least a 30% reduction in the circumference and volume of their lymphedema, which means that their lymphedema is improved by at least 30%. Some patients have actually seen complete recovery and the celebration of throwing their sleeve away. While rare, it can happen. So suffice it to say, transplanting lymph nodes from other parts of the body can be very effective. So lymph node transfers are very uncommon. You need someone that's highly specialized in microsurgical technique. These blood vessels that we're transplanting and sewing together are less than a millimeter in diameter, and so someone has to be well-versed, well-trained, and comfortable in microsurgical technique. So when we take lymph nodes from other parts of the body, whether it's the neck, the inguinal region, or the back, we make sure we're taking lymph nodes that are not essential to that area. So in essence, once the scar heals, there should be no untoward effects of taking a lymph node, really borrowing a lymph node from other parts of the body. It really shouldn't have any effects at all. The great new thing in breast reconstruction using your own tissues is the ability to transplant lymph nodes along with building a breast at the same time, as well as restoring sensation by taking a nerve that's not needed and connecting those nerves to the chest, and so in effect restoring sensation and restoring lymphatic flow, and oftentimes potentially preventing lymphedema from occurring in the first place. So reconstructing the breast at the same time as the mastectomy is performed, we can combine lymph node transplantation with taking your abdominal tissue together to not only restore and reconstruct a breast, but also add lymph nodes that were taken away during surgery in order to reconstruct a breast, but also to restore and provide new lymph nodes to potentially prevent lymphedema from occurring in the first place. So lymphedema is real. About 20% of patients with breast cancer will get lymphedema. But there's answers now that we can combine with our colleagues in rehabilitation medicine and our therapists to restore lymph nodes, to bypass lymphatic channels, and to potentially prevent lymphedema from happening in the first place. MedStar Georgetown University Hospital is really the hub of complex microsurgical breast reconstruction in the entire east coast of the United States. We have the internationally renowned set of surgeons that do things that are cutting edge, that very few places in the country, if not the world, provide, in the form of lymphatic surgery, lymph node transplantation, bypasses, preventing lymphedema from happening in the first place, and of course, restoring and potentially restoring sensation to a reconstructed breast.